Welcome everyone. Thank you for coming on this Wednesday afternoon to the 7th seminar in the Learning Together for Better Lives series. My name is Fanula and I'm your host. I am with the Health Determinants Research Collaboration Aberdeen, which is a partnership project between Aberdeen City Council, the University of Aberdeen, Robert Gordon University, NHS Grampian, and public partners. And our aim is to support the council and its partners in maturing their research activity in order to narrow the gap between research and policy making. As I mentioned, this is a series of seminars, so it is being recorded, and the recording and those of the previous ones in the series are all available on YouTube in the Community Planning Aberdeen YouTube channel. I will drop some links in the chat once I have an opportunity. Everyone but our speaker is joining muted, and you do not have the power to unmute yourself or share your camera yet, but I will grant you that power when the time for discussion comes. You have access to a Q&A area to drop in questions as they occur to you, but it's no big deal if you drop them in the chat as well. Today's topic is critical realism in evaluation, and as a personal aside, this is the one that I've been really looking forward to because it's the social science aspect of evaluation, which is a big deal in the provision of services by local authorities. I will also be dropping a link to a feedback survey into the chat, just a short, quick one, no mandatory questions, and it's all anonymous. We would appreciate your comments if you're able to share them. But anyway, on to the interesting bit. Our speaker today is Dr. Lucia D'Ambruoso, who is a researcher at the University of Aberdeen. Specifically, she's a social science and health policy and systems researcher. Her research is spread all around areas of the world, but does include inequalities in Scotland. And I'm hoping to learn lots today, so I've got my pen and notepad sorted. Lucia, over to you.
Thank you so much, and thank you kindly for the invitation. It's lovely to join. As you were saying in opening there, I will be talking about critical realism and what it might be able to offer evaluation, particularly for complex problems. All right, so in overview, I'll talk about this specific lens or theory, critical realism, what it is and what it's not. And then I want to talk about applications of it to injury care in low and middle income countries, to a decade-long programme. South Africa is the country I know best, probably in some ways better than my own. So I'll talk about how we've applied it there over a very long programme, looking at various different health priorities, alcohol, drugs, water, HIV and TB, and here in Grampian to look at smoking. And hopefully there'll be some decent time at the end to pull that together and have some discussion. All right, so I'm sure that I don't need to convince this audience about how theory in evaluation has certain limitations and certain opportunities. That well-known phrase, all models are wrong, but some are useful. I think in public health, we can be quite medicalized by default, and we can be quite linear in our thinking. We're getting better, and systems thinking is certainly mainstream, but we still have this assumption that social intervention A, if we inject it into the population, can give rise somehow to social impact B. And that's reasonable to an extent, but it overlooks a lot of complexity. And not just in the problems that we're looking at, in the context that we're working in. So we can think about complex problems and then complex context, institutional, social, historical, political, and these are all difficult to define, multi-dimensional, often contested, and often have a real knack of resisting any attempt at resolution or intervention. So we've got these layers of complexity. And I want to make a point that problems and systems that we work in are worth paying attention to. And one of the ways we can think about complexity is through this idea of wicked problems. So these are problems that are difficult to define, have no single owner, have unintended consequences from any intervention. So we can think about things like health inequalities, climate emergency, and so on. But data are also wicked if we think about it. Data themselves are difficult to define. What counts as evidence depends on who you ask. Data have no single owner. Again, I'm sure I don't need to convince a local authority audience that they're produced across fragmented systems with many processes, interests, and mandates. Data interventions have all sorts of unintended consequences. A new indicator, for example, can shift attention away from what it doesn't measure, and data are resistant to reform. Evidence infrastructures have their own logics and momentums to them. So there's a double wickedness here about the problem and how we generate evidence on it. And critical realism is a lens that's helped me navigate that over time. So to understand complex problems, including evidence itself, the point I'm trying to make is theory can help, but I think it might be worth distinguishing critical realism and realist evaluation. I'm guessing most people in the audience will be familiar with realist evaluation. It's used quite extensively. Indeed, the material on this slide comes from the Treasury and the Evaluation Task Force, the MRC's complex evaluation guidance is very realist and it's grounded in realist evaluation. And realist evaluation and critical realism are related, but they're not quite the same. So RE it's an evaluation method. It asks really important questions about what works for whom in what circumstances. And it does it through these CMO configurations, context, mechanism, and outcome. So here we go again with social intervention A and social impact B, and something complicated happens in a black box according to realist evaluation methodology. So it's quite intervention focused. Whereas critical realism is a philosophy of science. It's what we call a meta theory. It asks us to go a bit deeper. It thinks about what exists and why does that happen? What are the fundamental root causes of that and how might they change? And it has something called a depth ontology, and I'll come on and talk about that in more detail. And you can't get through a complexity seminar without lots of iceberg metaphors. So here's the start of mine. I like this image from National Geographic. But critical realism talks about this depth ontology. We have the empirical that we can see, but sort of underneath that, we have things we can't see so well or at all, the actual and the real. So it's more problem focused, but I will come on and talk about that in a moment. Basically, realist evaluation, to an extent, it asks sort of why questions, but it's quite linear, quite descriptive. Critical realism is more explanatory, non-linear. It wants to know what we know and how we know it, and has explicit social justice commitments as a result. So a bit more on this depth ontology. I think the core claim in critical realism is that the world has social depth and there's more going on than we can observe. So there's a kind of humility in it to an extent. And there's these three core domains: the empirical domain, what was recorded. So in my world, and I'm sure in a local authority world as well, it includes things like surveys, registers, administrative data, routine indicators. But then CR starts to think about the actual events that may or may not be observed. And we can think about that metaphor of things bobbing on the surface, sometimes concealed, sometimes not, sometimes both. And we can think here about things like informal care, stigma and fear, what people don't say in surveys, that easily dismissible, anecdotal, we are getting better, but the community knowledge that often never reaches services. And critically, critical realism thinks about the underlying structures and mechanisms that must exist to explain both those, the actual and the empirical. So here we can think about things like power, poverty, commercial interest, political settlements, and institutional cultures. And critical realism has a kind of logic to it called retroduction, where you infer backwards from observed outcomes, what you can see. So it's quite pragmatic. We use what we've got towards the actual and the real, what must be operating for us to have those critical signals. More recent scholarship around critical realism sort of sets out that while these structures exist independent of our understanding or at least observation of them, and they condition what people do, people can also reshape those structures over time. There's this thing called agency, individually and collectively, and it matters, including, for example, around how evaluators make choices about what to measure. So this is what I mean by what data can reveal and conceal. It's not to say that data are bad or useless. Data are important and we need data, but data are designed to capture the empirical, while the real, according to critical realism, lies beneath. All right, so let's try and apply that to these examples. I'll try not to spend too long on them, maybe just 5 minutes or so on each. So the first one's on injury care in low and middle income countries. The burden of injury, death and disability is tremendous. As this slide indicates, some analysis from The Economist's at least 10 years ago that first set out that the burden of injury deaths, the slide here is on disability, but the same trend exists with deaths. There are more injury-related deaths than there are deaths due to HIV, TB, and malaria combined. More than 90% of deaths occur in low-income countries and middle-income countries. Nearly half of those are preventable. As always, we have a burden of mortality and then a kind of shadow burden of morbidity and disability that's many times greater. An estimate suggests 40 million disabilities per annum. Curiously, there have been many decades of research and intervention, but care systems remain chronically under-resourced. I had the privilege of having a residential fellowship in Africa's only Institute of Advanced Study in Stellenbosch last year, and I worked with a team of injury care clinicians, and I would say to them, why don't we know about this? We hear about infectious outbreaks, cancer, heart disease all the time. Have injuries got an image problem? And they would help me understand that injury care, it spans quite a range of scenarios, from an elderly person with a hip fracture to a gang lord with a gunshot wound. Certainly a forgotten pandemic and certainly a wicked problem. There's no single definition of what is injury care. Is it prevention and road safety? Is it rehabilitation and discharge? Is it the ICU? Is it the emergency room? There's no start point. There's no defined end point, no owner, and no one solution. And as you might expect, many stakeholders, as I'll come on and describe, data are vastly incomplete and contradictory. Interventions have these unintended consequences. It might seem like a good idea to stand up an ambulance fleet, but if your emergency room isn't staffed and equipped, probably less so. So solutions are just better or worse. There's no right or wrong answers. And of course, these things are rooted in much deeper issues that are structural in nature, wider failures of labour, transport, housing, particularly in low and middle income countries, a massive economic burden. And interestingly, the impacts are kind of cyclical and intensifying. This stuff isn't static or linear. So a bit more on the measurement challenges with injury care. As I've been sort of outlining, despite the multiple strong influences on injury care, these upstream drivers, this is a bit like a depth ontology in some way. We never collect information on these social circumstances in clinical settings. Trauma registries across low and middle income countries sort of demonstrate this in action. They basically record age, sex, and injury mechanism. But There's nothing on referral, generally nothing on substance use, nothing on poverty, nothing on follow-up. The facilities that do record are usually better resourced and give a skewed picture. And certainly deaths en route to facility, informal care, those who never reach a facility never even appear in data. And as a result of all this stuff, declining aggregate rates overall can kind of conceal pockets of inequality and complexity and can mandate under-resourcing in context of rising need. So we've got these kind of simultaneous data deficits and data surpluses, and it's kind of wicked data in practice. The evidence system is designed to capture what the health system can see, not what generates the problem and who's excluded. So with clinicians, we developed a practical, critical, realist tool, and we sort of threw away the iceberg and we tried to be humble about what was underneath the surface. And the artist who painted this lovely picture very kindly allowed us to share it and use it for the purpose to kind of illustrate what we called a reading routine, to apply critical realism to the problem of injury care and injury mortality and morbidity. And it aligned to those three domains, the empirical, the actual, and the real. So again, it's not to throw out data. Data are important. So what can our clinical data tell us, particularly around patterns and distributions and trends? But then starting to think a bit deeper, who might be missing? Who might be misrepresented? What don't these data see? And then most fundamentally, what deeper mechanisms or structures might explain both what we observe and what we don't. So this was trying to operationalize in quite a pragmatic way for busy clinicians in service, the depth ontology and the retroductive sequence. And we applied that across various scenarios, and the Rana Plaza disaster was one of them. This is an image from it. So April 2013 was when this disaster occurred. It was the deadliest structural failure in modern history. An 8-story commercial building in Savar, Bangladesh collapsed, killing 1,100 mostly female garment workers and injuring 2,500 more. Of course, the local trauma systems were completely overwhelmed by this. Women and patients went untreated, weren't followed up, they certainly weren't compensated. And so the social impacts were profound and largely unmeasured. So we applied our reading routine to this, thinking very carefully about what hospital data might tell us and what they might fail to tell us. So of course the routine data would have registered spikes in admissions, surgical volume, early mortality. But then applying that retroduction sequence, going to the actual level according to critical realism, what happened, the seen and unseen. We could think about things like intensive rescue operations lasting for weeks, that hospital data don't show the repeated safety warnings, ignoring the structural cracks that had appeared in the building the days before, or the workers forced to return to the building under threat of losing pay, or that the building couldn't handle the vibrations of heavy factory machinery that was built illegally on soft soil, originally designed to be just 4 stories tall. And then inferring even further back, it didn't show the gendered labour precarity, the weak regulatory enforcement, and the transnational commercial incentives. There were global garment brands housed in that building. And all those together created and imposed significant predictable risk on an already fragile health system. And of course, this is talking about the commercial determinants of health. This is a contemporary, it's kind of established, still relatively emerging area of global public health. In 2023, The Lancet brought attention to it with a special series. And there's an article in there by Gilmore and colleagues that talks about the power dynamics between multinationals, between nation states and affected communities, just as we kind of looked at with this critical realist reading of trauma-centered data around the Rana Plaza disaster. And Gilmore and colleagues talk about as health harms from this system of commercial determinants of health increase. Troublingly, our ability to intervene decreases. There's another non-linearity there. And what's useful about critical realism is it makes this explicit, what routine data tell us and what they fail to capture. All right, moving on. I wanted to talk about work in South Africa as well. So this is quite a long program. I've worked there in the rural northeast in a province called Mpumalanga, up on the border with Mozambique, for 15 years, 10 in formal partnership with the Department of Health. So this is one of South Africa's poorest provinces. This is not Cape Town. It's more like the rest of Southern Africa than South Africa, I would say. There's multi-dimensional and intergenerational hardship and complex quadruple burden of disease, while HIV and maternal and child mortality are coming down. Violence, injury, and chronic illness in an aging population are exploding. There's quite weak and incomplete data systems. Really progressive health policy, pro-poor, inclusive and progressive, but implementation in a very fractured system with deep institutional challenges and then social, economic and historical challenges makes implementation extremely challenging too. So while in policy commitment, there's a huge revival of the district health system to reconnect people and services, in reality, there are very limited spaces, for example, for community voice. I work in a mature surveillance site that's been around since the apartheid era for over 30 years. This is an image of a typical village. So these are former homelands where there's high poverty, high unemployment, limited electricity, household water supply, etc. And we stood up this research programme with a sort of dual commitment and objective to produce better evidence on social disadvantage in health and try and support better evidence uptake. And we had these two techniques: verbal autopsy, which is a health surveillance technique to look at all deaths that happen in communities, not just those registered by the health system, and participatory action research to couple that statistical hard data with qualitative evidence, systematizing lived experience into collective forms of knowledge. So this was basically a co-production process with quite an inclusive way to bring evidence together. We didn't use critical realism in this program until just last year in our 10-year evaluation. And I want to share how we turn the critical realist lens on the knowledge production process, perhaps more than the substantive topics we were looking at. So as I said, we combined surveillance and mortality data with data on lived experience generated through participatory processes. And these focused on community-nominated priorities, not priorities we imposed as outsiders coming in. And that was really useful and immediately connected us to other sectors. So communities raised and framed lack of clean, safe water and alcohol and drug abuse as the main health concerns in the rural villages we were working in. And it was useful because it immediately took us into a multi-sectoral process. Interestingly, of course, the Department of Health has no mandate over water, although there's no health without water. But it did get us into some tensions with institutional mandates and expectations from the Department of Health. It also revealed deeply entrenched social inequalities and how they intersect with a fragmented statutory sector. And of course, with the resourcing and governance challenges to meet complex need. So these are some examples of the statistical data we were able to generate working in the surveillance site and how we tried to combine it with lived experience data on lack of clean, safe water and on alcohol and drugs. And interestingly, when we took all the surveillance sites data right from the start of its existence in 1993. This gold line at the top is all the deaths we could attribute to alcohol or drugs or lack of water. And it was this troubling, large burden over decades. And that immediately said to us, listen to your community. They will tell you important things. So knowledge was collectively produced, not extracted, and we were very concerned with participation and sort of reflecting and re-reflecting on our co-production processes. And one of the ways we did that was to expand our participant base depending on the issues that were surfaced, thinking very carefully about whose voices were in the room. So the image on the left here is when we first started. We worked with women of reproductive age in the community. You can see a researcher standing and a research participant talking about a piece of visual evidence. By 2019, we were working with youth participants directly affected by alcohol and drugs, building their voice and agency to raise and frame issues. So here in the 2019 image, one of our youth participants is facilitating a discussion, selecting, captioning, and deliberating over visual data. When we sort of developed a sufficient amount of locally relevant data and evidence and a sufficient amount of community capability for community voice, not to sound paternalistic about it, but a sufficient degree of confidence and capacity, especially amongst vulnerable groups like youth affected by alcohol and drugs, we went into dialogue with the health service and we developed joint action plans, which we implemented and evaluated in these repeated cycles. And this is no small thing in a place like in Mpumalanga province. There's a long tradition of violent protest and specifically violent service delivery protest, basically because there's very little opportunity to engage. There's no language left in a deeply challenged system. And we produced this we were seen as the scientists were very neutral arbiters. Of course, we weren't. We had our own agendas, but we were seen as neutral and we could facilitate these connections between service users and providers. We had these repeated safe encounters, a predictable presence, and we learned a lot about layers of social hierarchy and institutional hierarchy, I think, that exist everywhere. And our evaluations and follow-ups of these local action plans we would generate through the process soon became very appreciative and non-punitive, a kind of compassionate accountability. And through all this, we developed presence, relationships, collective sense-making with different actors, bringing different pieces of evidence together, and that helped us understand very complex realities, and it increased the agency of everyone involved with. We found quite quickly that when we took this evidence to people we assumed had some degree of power to act on it, they often had little or none. And the process soon became one of mutual empowerment, not just community empowerment. And over time, those repeated action learning cycles became more local, more legitimate, more actionable, and more widely owned. So the kind of context of fragmentation and hierarchy, when we put this carefully managed co-learning process in, we kind of stood up this relational stability. And then in 2020, everything changed. Just as we were starting our second cycle, COVID came along, and South Africa, of course, had one of the strictest lockdowns in the world. So we completely redesigned the process with everybody involved, and community health workers were identified as those we should focus on. They're key agents in this district health system to connect people and services, but they had really poor connections in communities and they were completely disregarded by the health system. They weren't even government workers. Probably the equivalent of care assistants in some ways in our contexts, but had deep associations with HIV. So they would be chased off of people's homesteads, for example, when delivering their chronic meds like insulin because of associations with HIV care and the entrenched stigma around HIV. So we attempted to democratize our research methods, the verbal autopsy and the participatory action research, by aligning them with statutory competencies for community health workers and putting these tools into the hands of those dealing with the burden of disease, not outsiders trying to measure it. And immediately from sort of February 2020, community health workers shifted the process to focus on HIV and TB. When everyone was concerned about COVID and hands sanitizing and masks, TB was still around, and of course, a respiratory condition. It took the international community a while to catch up with this wisdom. But through that process, I think we ended up embedding into the health system. We moved into routine structures like the district health management team. We created our own learning platforms, and that agency that we'd started to engineer and support became institutionalized. And we've now worked with many hundreds of community health workers right across the province. The process has been taken up into primary healthcare in the rural province of 5 million. Yeah, as I said, democratizing these research techniques and institutionalizing this form of agency in a sense. And our evaluation that was informed by critical realism showed us that even in quite challenging contexts, health systems can become learning health systems that are adaptive, evidence-driven, and grounded in lived realities of the people that they served. So this sort of decade-long program evolved through COVID. It shifted from sort of sole community control to a community health worker-centered district governance model. That eventually got this kind of institutional mandate. And we saw a lot of useful outcomes in terms of skills of community health workers, their relationships and their identity. And as I say, critical realism helped us identify the kind of specific mechanisms of change that come out of those historical institutional contexts layered up against one another, and how through harnessing those agency mechanisms we can change both relationships and institutions. So through those repeated co-production cycles, capabilities and institutions were gradually reshaped, and we were really able to isolate what they were around trust building, role clarity and status recognition, through that collective safe space learning and sense making, and of course through the empowerment and agency. So turning the critical realism lens on evidence production itself was really instructive to us, and it helped us understand that the evidence generation process itself can be considered an intervention, and quite a powerful one. All right, if there's a few minutes left, I have one final example. So we've basically applied that process here in NHS Grampian to look at smoking and the cost of living crisis. So in 2022, with some support from ASH Scotland, CR UK and the British Heart Foundation, we applied a version of it right here. We didn't have 10 years, we just had 6 months. We were looking at smoking in a post-pandemic cost of living crisis context. With redeployed services starting up again around things like community-based health improvement and smoking cessation. And we had a similar kind of data and dialogue process where we brought diverse forms of evidence together, deliberated over them in communities and then with the health service. And as the health service was redesigning and redeploying its services post-COVID, it was a kind of prospective policy analysis. We walked in step with service. And the picture here, there's some of the brilliant health improvement officers from NHS Grampian who showed up and community spaces. So these were recovery spaces up in Fraserburgh, Banff and Peterhead, to appraise the different forms of evidence we'd collected together and think about. They were extremely open and in some ways vulnerable about their services and the limitations of them, and listened very carefully and engaged with communities as we were raising and framing smoking, another sort of complex social problem. So applying that reading routine again, we arranged data we had, routine, statistical, statutory, and service data, where we'd see all the sort of familiar things we often see in terms of social stratification and patterning. But with lived experience, we were able to get to that slightly deeper level of the actual, how stress and debt and social isolation and social norms affect things like smoking. And the depth of critical capability in rural communities was really phenomenal. We were able to get to those fundamental root causes around poverty, commercial determinants, retrenchment of welfare, commercial interests, and so on, that really helped us understand how agency is significantly limited with those wider sort of structural forces at play. And I just want to pause on the depth of that community intelligence. Even in this short pilot, we were getting sort of real-time critical analysis on those fundamental, real root causes, the commercial interests, the limitations of statutory services, especially post-pandemic, and how they constrained individual agency. So e-cigarettes came through loud and clear as a deep concern, and a variety of concerns within them: widespread availability, affordability and acceptability, fewer restrictions everywhere, widespread dual use. People reported feeling more addicted to nicotine because of these so-called cessation devices. Real anxiety over the long-term health effects, the explicit targeting of children, implications for people who'd never smoked, and environmental impacts. And all of these undermine cessation and encourage uptake. This is a deep critical analysis. This is the kind of political economy we desperately need in public health, and do quite rarely, actually. And communities underscored, with minimal prompting, significant collective harms and regulation as an imperative. And of course, that was confirmed most recently, wasn't it? At least the environmental impacts. This is an image from the Glasgow fire, which for me makes me remember the Lancet special series on the commercial determinants, and about how the health harms from this system of power dynamics between multinational nation states and affected communities. The health harms from that system increases our ability to intervene, decreases, and perhaps is something behind the community's kind of imperative over the regulation recommendation. So overall, thinking about both the substantive topic of smoking in this example and the evidence production process itself, we saw inclusive and different forms of evidence, conventional and from community voice, combined in this critical analysis. And again, we saw this mutual empowerment and relational learning, even in this small pilot. And again, critical realism helped us isolate mechanisms around this, about dialogue, safe spaces for regular discussion, both in these community recovery spaces and in, you could argue, more professional or academic spaces. This is the university library. And of course, the other side of, dialogue is listening. These repeated and regular and predictable safe spaces, and that in those encounters, we're capable of generating new forms of evidence and capability for evidence and action. All right, so across those examples, the injury care one, I was trying to highlight how routine indicators can obscure deeper structural causes of harm. The South African example, I was showing how the participatory process generated new forms of knowledge, agency, and action. And the Smoking project demonstrated how community intelligence can reveal key mechanisms and broader structural drivers that are quite invisible in routine data. So I've been trying to make the argument that critical realism gets us to the root of the problem, to those underlying structures and mechanisms. It helps us understand why harms persist, and it avoids that separation of connection between social, historical, political, economic, institutional, and community contexts. As I've described, we turned the CR lens on evidence itself, and that really helped us think critically about what data show us and what the limitations of data are, and indeed what counts as evidence. And that has taken us towards these mutual and relational forms of learning, which together generate new knowledge and forms of trust and recognition. So if critical realism helps us uncover the root causes of problems, I think my experience of it shows that it also helps us recover the relationships through which understanding and change become possible. So while evidence isn't enough, I think I've been trying to argue how we work together to produce it can be where change begins. I should have a big shout out to sponsors, STIA in Stellenbosch particularly, and NIHR that have supported this space as well as a lot of the injury care work, South African partners and those in the UK also. Thank you very much.
Brilliant. Thank you, Lucia. That was very, very interesting. And a lot of the points that were coming to mind as you were speaking, you came back to towards the end there, and I appreciate that. What I'm going to do now is grant folk the power to unmute themselves and turn on their cameras. If you have a question and you are the type, you can shout out, but equally you can drop them into the chat or the Q&A section. And while you're doing that, I'll just abuse my position and ask my questions because that's my prerogative as the host. I mean, the first thing is retroduction. What a word. That's going to be like, I think, my superhero name, I think. I'm going to be retroduction. I think that works. Some of the points that came to mind for me as you were speaking, you used the phrase that in your second example, the researchers were seen as neutral arbiters. But in a local authority context, that's not going to be the case for officers. So what would you advise officers who are trying to evaluate an intervention that they've designed? How would they navigate the real component of your depth ontology where they are always going to be perceived as agents of the administration, whichever administration that is? Do you have any thoughts on that?
Thank you. It's a brilliant question. It's something we've struggled with for a long time in South Africa. I think I don't mean to sound flippant, but I think it's reasonably straightforward for a research team who are deeply committed to experiment with a process and make it work, invest a lot of energy and demonstrate an outcome. For me, the real question comes, and again, you'll excuse me talking quite crudely, but when no one cares, when it's everyday practice and it's that thing we have to do, and they can be night and day. As I say, we grappled with this in South Africa a lot, and we thought very carefully about sustainability and engineering ourselves out of how we stood up those learning spaces. And our experience suggests that really focusing on those key connectors. So for us, it wasn't kind of, I'm struggling not to use hierarchical language, but I guess higher level policy officers and managers and planners. We were working with those community health workers, some of whom had limited or no education. Some of them had reasonable and high school education and were completely capable of going on to potentially nursing careers. But there was something about that cadre of health worker. It was more than a glass ceiling, it was like a concrete ceiling between the social kind of view of them as part of the HIV care machine and the institutional view of them literally, and this is a quote, the dumping ground of the health system. As I said, there weren't even government workers, no pensions, no sick pay, no holiday pay on the equivalent of 0 hours contracts. So I think it was thinking very critically, carefully, and collectively about power in the evidence generation process and deliberately going towards those most directly affected. So to answer your question directly, I think it would be around a lot of kind of self-reflection about extensive power and how to share it, and how to be mutual and humble. I was trying to convey a bit of appreciation when I was given the Scottish example about the health improvement officers from NHS Grampian. I don't think, and I often say in our teams, we can't expect statutory service providers to show up with that degree of humility. That's not something we can necessarily reproduce. But to answer your question, I think that's what we need, and we can encourage ourselves to do together with a deliberate and repeated focus, like reflecting and re-reflecting about who's at the sharp end and who's in charge.
That's excellent. Thank you very much. The other question that I had was when you first introduced the depth ontology. And actually, it would be maybe helpful for everyone if we had that slide on the screen. Is that possible? Just as a reminder, because I know some people joined after that. I'll give you a second to do that.
This slide is very old school with the blue and the yellow.
Well, it is, isn't it? Yeah. But I'm retroduction, so it suits me. So what I was thinking about here, the real layer, power,
Yes.
poverty, commercial interests, logically, a lot of interventions, when they're evaluated, taking the critical realism approach, come down to these issues. In which case, that creates an opportunity for the naysayers to say, wait a minute, you had this small intervention, and you're saying that, well, the real issue is that we need to rearrange the whole of society. How can that be right? It creates an opportunity possibly for people to dismiss your argument. So what would your advice be for anticipating and precluding that kind of an objection?
Thank you. That's another brilliant question. And just quickly on terminology, one of the trickiest things about critical realism is its terminology, with retroduction and depth ontologies. As a product of a migrant family, I quite like disentangling all this terminology, and they aren't that complicated ideas underneath it. But to answer your question, absolutely. The injury care clinicians that I worked with at STIAS were asking me pretty much the same question. Like, what can we do about global garment production? That's not in my remit or my training. Well, absolutely, of course. A busy emergency room doctor is not able to take on the global garment industry, but we do routinely measure things. And what critical realism gets us to do is think about, as I was saying, what's there and what's not there. I really like it because it's so pragmatic. It's not about throwing the baby out with the bathwater. These routine data are hugely important. They're also public goods, frankly. The public own these. And they deserve scrutiny, but it's in the scrutiny we can get to those deeper layers. And while they might not be within the statutory mandate, is it not reasonable through pretty simple techniques to be able to signal that these issues are at play and send that information up the chain, as it were? And that was how we kind of reconciled that issue at STIAS. Well, it's not a core statutory mandate to take on those commercial drivers. A, we can't ignore them, and B, it is within our analytical gift to go there and report.
Thank you. I appreciate that. I see some questions are in the chat. Brendan has put one in. He's put apologies for being a recovering philosopher. So his questions are fairly lengthy, but let's go with the first one. Brendan's view is that the hardest bit about critical realism to explain to people is the distinction between real and actual. So how do you do this when working with stakeholders in that nobody cares context? What's the value of that distinction for you in your work, and where does it get you?
Yeah, as I was saying, the terminology in critical realism is a bit of a barrier. I think it's entirely surmountable, but there are some linguistics there. So to get to the question, to explain to people the distinction between the real and the actual. So the actual is about events that may be seen or unseen. In the Rana Plaza example, I think at one point I was talking about, trapped workers in a collapsed building. They are events that give rise to empirical signals like trauma admissions in an overwhelmed facility. The real is different to the actual in that the real are the structural conditions that must be true to give rise to those events, seen and unseen, the bobbing of the iceberg, as it were, or the whale with our injury care reading routine. And those events are what give rise to the empirical signals that we can see. I quite like that trinity. For my mind, that is reasonably simple, and the degrees of visibility help as well. And that distinction between the empirical readings, the events seen or unseen, and the much less visible structural conditions that gives rise to both. I hope that answers at least the first bullet, Brendan.
I'd strongly encourage you to ignore the rest of them. I was just saying, I wanted to say something and I was going to disappear. But thanks very much. The presentation is really great, and what a lot I've learned. It's been absolutely brilliant. Thank you so much.
All right. Well, thank you kindly for the question.
Yes, we'll take you at face value, Brendan, so we won't follow up with the other bullet points, but equally we can come back anytime. Anyone else, do feel free to raise your hands along the way or just start talking. As you were explaining particularly the actual level, I was thinking, oh, this sounds a lot like lived experience. And of course, as you progressed, you did introduce that quite significantly along the way. Is there crossover between lived experience I tend to think of as a data type, but maybe I should be relating to it differently there in the context of critical realism. Do you have any views on that?
Thank you. That for me, I was feeling quite bad when I was preparing the notes for this, saying, oh, public health is medicalized, we think in linear terms, A to B. And then I sort of checked myself and thought, well, no, systems thinking is mainstream now in public health. The state is realist. As I was saying, that was Treasury Evaluation Task Force methodology in the slide on the distinction between critical realism and realist evaluation. So this stuff changes. Maybe the lived experience is co-production, inclusion, participatory methodologies, and all the related are kind of bobbing above the surface a little bit more and kind of, fossilizing into that empirical domain. I would say there's a dynamism here. And I was trying to make the point when I was going on about agency. It was Margaret Archer that came along and sort of said, okay, structural determinants, all very well and good, but people can affect this stuff slowly and over time. And I think that's reflected in what you're pointing out. This stuff that can be seen and unseen, a lot of lived experience data is up here in our empirical, but a lot of it is still dismissed. A lot of it is still not spoken about when people are talking in surveys or in co-production processes. A lot of people aren't even reached for those processes. So I kind of like this model of thinking to keep that reflection going and think dynamically about what evidence is and where it exists. And it's a bit of a particle in a wave. It can kind of be in those two categories. And lived experience is a brilliant example of that. There's a critical public health academic who was grumbling in one of the listservs yesterday about how public health institutions and researchers are part of the problem that they're trying to describe, and it makes it almost impossible. And for me, confirm this idea about continual critical reflection as part of our methodology. Going back to your first question about, whose voices are these anyway, and so on. Does that answer your question, though?
I think it says, yeah, and it's continued reflection for me as well as someone who's learning all of this. There's a couple of other questions in the Q&A. So B has said that she's interested in the time and capacity requirements of doing an evaluation of this nature. Can you shed any light on the scale of work involved to take this approach in evaluation? And are there ways to minimize it whilst not compromising?
That's the absolute nut to crack, isn't it? And that's what we were trying to do in STIAS, come up with a practical, transferable tool for busy clinicians to work with the data they have. This is not to suggest that emergency room doctors should be or are able to, do lived experience work, do political economy necessarily. But a lot of this type of evidence does exist, and we have this thing called the internet these days. That means a lot of this information is right at our fingertips, a lot of times more accessible than our routine data. So I very much value the pragmatism of critical realism, as I was saying, not throwing the baby out with the bathwater, but being aware of routine data and its limitations and possibilities. So even just looking at our regular service data, we can tell a lot. And these are really questions, aren't they? Thinking carefully about who's in there and who's not. And then those deeper structural, and I think the Scottish pilot underscored this stuff's not rocket science, how obvious this stuff is. People aren't daft. It's reasonably straightforward to infer this stuff. There's something about the critical license to do it. But absolutely pragmatism is the name of the game. And as we apply this practical tool, I think that will be one of the key things to look at.
Yeah, absolutely. I'm glad you make that point, because when local authority officers are engaging with academic content, sometimes it could feel like you have to be perfect or don't bother at all. So the prioritizing pragmatism, I think, is a really important message.
I think I've been schooled that, sorry to jump in, really well working in low and middle income countries where data are very partial. And it's that balance of something, that's why the theory appeals to me, to get to that, let's say, depth explanation, not depth ontology, but also in a way that's very, very real, very practical.
Fab. I see there's one more question in Q&A, and David has his hand up. So I think the Q&A one came in first, so we'll do that, and then we'll move to you, David. So Martin says that communities bring stuff to local authority officers for change, but the local officers are curtailed by power dynamics within their culture. So does the agency of agents allow for mutual empowerment in that context, do you think?
I think that's where the repeated predictable process is useful. Again, having trained and worked most of my career in low and middle income countries, I've seen a lot of extractive and decontextualized working, that kind of parachute model where people come in, collect data and leave. Our model became deeply relational over time. I think we over-focused on communities to begin with, but the tensions that brought up were very useful and instructive. But it was during COVID when in South Africa we worked intensively with community health workers. And to begin with, those community health workers had very little voice, agency, authority, or resource to stand in front of a higher level planner or manager at sort of district, sub-district, district or provincial level. By the end of our process, by having these repeated safe space encounters, it was entirely possible to have more, to create those conditions of listening. But it comes back to your earlier point about the neutral arbiter. And again, the real question for me is, when that leaves, what does that mean for people who are less neutral comparatively? And I think that's an unresolved question. But at least from these applications of these kinds of techniques, it is possible to do, to sustain, and to scale.
Fabulous, thank you. And David, you've been waiting patiently. Thank you so much. Would you like to speak now?
Thanks. I switch a camera on, but I can't do that. So folk are okay. I'd like to make a few comments and start by saying I'm not a health practitioner. I suppose I call myself a community practitioner, having been project manager across the different sectors over many working years. And now I'm a full-time charity trustee in Torre. Couple of things here. I find the presentation interesting, but my background got attracted to this particular presentation because I appreciate and know the need of being able to critically evaluate an idea, a project. I know about the interplay between how you've got to look for tangible outcomes when so much is intangible. I think I remember it was Sherlock Holmes who said we've got all proof but no evidence. And there are many things that bring benefits, but sometimes they're not always understood. I can think of some of the work we do at Old Torre Community Centre and give an example of that in just a moment. So I suppose the first thing I'd like to introduce is there's a lot of jargon, a lot of terms here.
Yeah.
It's not very friendly and engaging. I can't think of anybody I know who talks like this. So there's something to be done to bridge between how you look at something and give an analysis to it, but how you reach out and engage and talk with folk to get their interaction. We've had some experience of this. Folk don't like doing surveys, but given an opportunity in a kind of comfortable, safe sort of setting, an opportunity to talk and be listened to, it's surprising the amount of nuggets that will be thrown out and come into any conversation.
Totally.
Part of that background I have was more rooted in the built environment. I come from a family of engineers and builders, and I remember always the comment, the health of the people is the highest law. Trouble is, not many people see that health affects what they do. So you get people like me raising issues about winter road maintenance to be told, oh, well, you know, you have to restrict the budget. And I said, yes, it ends up being 3 times the amount being spent because of folk in Torre who slip over on untreated footpaths because they can't, it's either not safe or they can't get around. And the conversation just freezes because it's not joined up or linked to the consequence of actions by somebody in one area and where it ripples through into others. Again, relationship between health and housing goes back centuries. And yet we're still making arguments today about warmth and how you heat and how you ventilate properties. So it's how to get a narrative that is perhaps easier for more people to be part of and feel that they can not just have a say, but they are really being listened to. And I would suggest that an issue here today is how to take that away to broaden the dialogue and involve the community sector more. Yes, through development trusts, through community centres and other community type organisations, because the data's out there and it's evidenced in people. it's how you get it. So I'm quite happy to make further comment on this, but maybe I've said enough so far, and somebody might want to pick me up on something or pick up a particular theme and introduce it into this discussion. But I certainly wanted to say I've joined in because I think it's relevant for what I see, but it's how to broaden that and engage with more, that they can see that in all the sectors, whether you're working at a community level or policy level, lawmaking level, you've got a part to play. And there are consequences of doing things. There's consequences of not doing things.
Thank you. And I think it really underscores, I've underlined it several times in my notebook, this point on terminology and how what might be potentially, at least in my experience, it's been useful, practical, critical technique to get to the root of the problem and to think very critically, as you're, I think, David, encouraging us to think about how, with whom and for whom data and evidence are produced in the first place. The idea that terminology can be a bit of a barrier, absolutely agree. And you're encouraging me to think further that maybe some kind of translation exercise might be worthwhile. On your point about, listening brings benefits, but they're not often well understood, I totally agree with that. The New Local had a brilliant evidence review of community power initiatives. No one calls them community power initiatives. That's what they are. We all use empowerment, inclusion, participation, you name it, but we rarely say power. And the New Local talked about how community power initiatives are stuck in an evidence paradox. They're always trying to demonstrate their benefit according to the usual metrics, and they're not fit for purpose, as you're saying. As I was trying to say, their benefits intrinsically as well as instrumentally just from being listened to and heard. And I think we can do a lot better at evaluating those kinds of things. The conventional is important and we need that stuff. It's not to say we can't kind of experiment. And then on your point of health and place, and gritting the roads will pay you back much more than keeping the emergency department triple staffed over the winter period. Completely agree. And that's the point I think I was trying to make about, in the injury care example, where structural determinants drive this burden, but A, they're not collected, and B, as we talked about, who's got the mandate to intervene on them? That doesn't mean that we shouldn't look at those things and document them. And we do have tools to do this. So it's kind of frustrating and motivating in equal part to me to think about the barrier of terminology. And that's certainly an area I'll think about more in future. Thank you very much for the comments.
Brilliant. Thank you so much, Lucia. I'm just checking if we got any. One of the comments, I think this is when we were talking about in the iceberg, what is it, what level? Lucia is saying stigma, can it be both actual and empirical depending on whether it is experienced by a person or not? So if someone replies dishonestly because of stigma that they don't realize, that would be actual. But if the person realizes that they're experiencing stigma and report it as such, would that be empirical?
I think that's a bit like the point we were discussing, isn't it? Thank you for that point again. It's probably worth looking at. For me, that's the bobbing ice fragment, isn't it? Yeah, what people say in surveys and in data collection may or may not represent what's really going on for reasons like stigma. So yes, I think it's that some of these things can appear in either and both. Indeed, the International Classification of Diseases, version 11, which is forthcoming, contains new social codes on issues with access to healthcare and so on, that shows how real institutional architecture for how we think about cause of death is starting to go into the social. So, as we said earlier, I think there's something of a fluidity here. The empirical, the actual, and the real to an extent. We can think about how these aren't rigid categories. And as we were talking earlier about how co-production is mainstream, lived experience and stigma data can be well there in the empirical, but it's not outside the realms of possibility to think, well, maybe there are some less seen or sometimes completely unseen aspects of things like stigma in existence.
Brilliant. The asker for that has acknowledged the helpfulness of your question, so that's great. I don't see other questions in progress or posted. Please do anyone shout out if I am overlooking yours. I don't want you to miss the opportunity to quiz Lucia while she's here, but equally, maybe you'd like to be gifted 20 minutes of your day back and 10 points for whoever can find the sun, because I haven't seen it for a while.
Same here.
I have dropped a feedback link into the meeting chat. If anyone would be willing to provide feedback on the session, we'd love that. What I sometimes also do is I'll try and produce a 1 or 2 page plain English summary from some of the seminars that we've done. I mean, that might be quite an interesting exercise to just try to see.
Yeah,
can
based
that be
on
done?
what we've talked about, I'd be really happy to work with you on
Yeah.
that, especially around the terminology, maybe even the stigma example we talked about at the end there. Yeah, I'd be really interested to do that, if useful.
Yeah, I've done it for previous seminars. David, I see your hand is up again.
Yes, thanks. If it's kind of coming to a close, could I just ask or make 2 quick comments? What happens next is the first one, but can I also just put out an appeal that there's a lot, I think, that can be learnt from what's going on in the community sector. And I'll give a quick example. It was years ago back during COVID where the centre was a vaccination centre. From a time when it could only be done in clinics and hospitals, and suddenly to reach hard to reach communities, there was a need to get into communities. And the health service manager I spoke to, we got talking about how the centre was funded. And I said, really, the health service should be supporting community centres. He said, well, you don't do health. I said, we contribute and help towards mental health and well-being, social isolation, keeping people warm. And I started to run out of fingers. And he said, oh, I'd have to think about that, but I see where you're coming from. I said, yes, we are very active in well-being. I said, communities assist well-being, clinicians help illness. And they're 2 different roles, but they can be complementary. So it would be asking that folk give that some thought as well. There's a wealth of knowledge and talent and experience in the community. It's just getting to a point of being into that dialogue and engaging with it. Hence, I ask, what's next?
Thank you again, David. They're brilliant questions. What's next? In South Africa, as I said, the process has been taken up in primary health care across the province, and the province is pretty much the size of Scotland. It's a rural province of 5 million, and we're currently readapting it at the moment as community health centres take on responsibility for normal deliveries. So part of the maternal and child healthcare services at community level. Soon, community health centres will have to manage normal deliveries and refer complications. And maternal and child health, while it's done reasonably well, the surveillance site I work in shows that half of all child deaths aren't seen by the system. So we're readapting that collective agency co-learning process across primary healthcare and specifically towards this, again, another kind of prospective policy analysis, working in step with services as they are rolled out. to understand them in the kind of specific appreciative way. And then we're also introducing or hoping to introduce the framework to look at youth addiction more broadly in Scotland. So we've just entered a partnership with Glasgow, Edinburgh, the Scottish Centre for Social Research, ASH Scotland, Public Health Scotland, and some others, hopefully bringing 2 health determinants research collaboratives together to think about how this kind of lens, just like we're saying, can be used in routine practice to work with the data we have and understand what they do and do not see. And then your point about social determinants, if I understood you correctly, and the wealth of community intelligence, that was absolutely confirmed in the Scottish pilot of this process. As I said, we didn't have 10 years up in Fraserburgh, Banff and Peterhead. We had 6 months. But the depth of, and I keep calling it community intelligence because that's what it was. It was deeply critical and multifaceted. It was elaborate and preempted. You know, it was talking about risks of harms that then came to pass with that Glasgow fire. And confirms, I think, what you're saying as well, the depth of critical capability at community level, and perhaps goes back to some of my remarks about it all exists there. You know, statutory providers want to meet complex needs and complex needs want to be met. It's about creating the spaces to do that with and without so-called neutral researchers, as we've been discussing. And it gets to that frustration. I think a lot of your remarks have been around the social determinants of health. Everyone gets it in principle, but we don't in the health sector do very much at all about it in practice, and certainly not in our routine data. But that's an entry point to push at in my book.
I love it. Thank you so much, Lucia. So many points for us to continue to reflect on as practitioners, but also hopefully collaborate on a bit further down the line. David, your point about what's next for the sort of the HDRC Aberdeen context of that. You'll know, I imagine, that the local outcome improvement plan is brand new, having just been recreated for the next 10-year period, 2026 to 2036. I don't want to put words in people's mouths because I'm a peripheral to the design of that, but as I understand it, there are more opportunities for community involvement there, and I believe that there will be continued opportunities for community involvement in HDRC projects as well. That's, as a reminder for folk, I'm from the HDRC, that's the Health Determinants Research Collaboration for Aberdeen. The next seminar date isn't set yet, but do please watch this space for the next one coming up. And the recording of this one will be on the Community Planning Aberdeen YouTube channel, maybe even as early as this afternoon if it downloads for me quickly. But thank you so much, Lucia. Really, really engaging and interesting presentation. I appreciate it hugely. And I hope everyone enjoyed it as much as I did, because I've got a lot of reflection to do there. So thank you so much, everyone. Enjoy the rest of your afternoon.
Thank you again. Bye-bye.